Hi, this is Dr. Toby Moma. I'm a family physician, assistant professor at the University of Mississippi Medical Center. It's a pleasure to have you with us on Health and Wellness with Dr. Toby. This few weeks, we're going to be talking about arthritis, bones, orthopedics, and we're delighted to have a special guest on the show, Dr. Timothy Spires Jr. Dr. Timothy went to some of the best schools in the nation, LSU Baton Rouge, studied in zoology. Then he went to UT Houston for his medical school, and then ended up at the Greenville Hospital System in South Carolina for his residency in orthopedic surgery. He's currently a partner, is an attending, a faculty, a director on the Northeast Louisiana Orthopedics Clinic on Louisville. You can't miss it, right there on the Louisville. He's one of the leaders in that community, in that hospital, in that setting. And we're going to be talking with him about joints, arthritis. One of the most common complaints we have in America today is joints. 80 million people back pain, multiple people, millions of people with joint pain. So we're going to be dissecting what is causing all this and where we can prevent it. Don't forget, our job here is to keep you well, because 3 John verse 2, God said, I wish above all things that you be in health and prosper. So join us on this show. I know you'll be blessed. Thank you so much for listening. God bless you. Look forward to seeing you same time on this station. Stay tuned. Thank you. Hi, Dr. Toby here from the University of Mississippi Medical Center, family physician, health and wellness host. It's a pleasure to have you on our TV show. I have Dr. Timothy Spires with me. He's an orthopedic surgeon with the Northeast Orthopedic Surgery Group in Monroe, Louisiana. They have offices in West Monroe, Ruston, and I want you to check them out if you have any needs for the orthopedic surgeon. But he's such a warm, ebullient personality. He's been educating us on arthritis and how orthopedic surgeons relate to pain and joint pain and when they operate. This session, we're going to talk a little bit about what goes on in the different joints of the body. Now, statistics show that Louisiana, I think, and maybe Mississippi, have the highest amputation rates in the country. They tell us in our medical textbooks that amputations are maybe $40,000 to $50,000. Why do we have such a high amputation rate? And I know you don't do all of them, but you do some of them. Am I correct? Amputations, are they in the turf of the orthopedic surgeon or the vascular surgeon? Who does
It
more of
depends.
them?
Where I trained, that was vascular surgery turf.
Okay.
Here it's kind of general surgery, orthopedic surgery, and even podiatry does some as well.
But why do we have such a high amputation rate in our state? Do you think some people, and I'm just talking about people in the audience, they feel they're doctors who are just knife happy. They want to just cut the person at the slightest sign of disease. I'm sure this is not true because I'm a physician and I know my colleagues are not unethical. But there might be a reason why we have such high amputation rates in the state of Louisiana and Mississippi. What do you think that might be related to from your experience as an orthopedic surgeon?
I think it's because they have the best food
Oh,
in
really?
Louisiana, Mississippi, and so people are incentivized to eat and not necessarily eat the healthiest.
What's your criteria? I mean, I don't know how many amputations you've done since you've been here, but what do you look for? Do you feel the leg? Some people say, oh, the leg turned black, the leg turned cold, oh, the leg is smelling. What do you look for before you do an amputation? Just because a lot of people are, there are people who go around and they actually allege that the doctor took my leg off when I didn't need to take it off. And I'm like, well, that's not likely. So can you educate my population listening to me why the surgeons take their foot off?
Well, the reason you take it off is in theory it's life preserving, because if you have something that's infected or is essentially tissue that's no longer alive or almost essentially dead tissue attached to your body, it's not good. It's a way for infection to get in the bloodstream, which can cause sepsis or infection through the whole body in your bloodstream, which can be life-threatening. The infection tends to get into the bone. It can get into the muscles. It can, if it untreated, you get terrible things like it's a terrible sounding word called necrotizing fasciitis, where it's a whole bunch of bacteria that gets along the tissue planes in the body under the skin, and so you may not see it until it's too late. And the reason for amputation is that when you have tissues that won't heal, and a lot of it's a combination of both diabetes and changes in the blood flow from the little blood vessels that bring blood to the extremity or to the foot. And when you don't have enough blood supply, then you can't heal an incision. And so even if you wanted to, so someone has a toe that turns black or has an ulcer that won't heal for 2 years, and you've been in multiple rounds of this and that, you can't do anything activity-wise because of that toe, and you have an amputation, to get rid of that non-healing part of the body, to allow the body to heal, the issue is that you've got to make sure that you do a surgery that can heal. So you have to have skin that's going to heal, and that means you have to have a certain amount of blood supply to it. And there are guys that like to advocate seeing a vascular surgeon first, so they can look at your blood flow and even do sometimes surgeries to increase blood flow down to the extremity to allow for healing, and that may actually cause wounds to heal. You have options with some of the wound care where they can do what they call hyperbaric, where they put you in a chamber and they actually increase the amount of oxygen in the air. So the idea is going to get more oxygen in the tissues to allow the body to help fight infection and heal the tissues better. And that's been having some, I do think there's some success there. It's hard to prove necessarily in the literature. And then just good wound care. A lot of times that, especially with ulcers, is that the old saying, an ounce of prevention is worth a pound of cure, is critical as an individual, as a Christian. Just I want to let you know that if you take care of your temple, and your body is your temple, that you can avoid a lot of these issues down the road. It means good foot surveillance. It means if you're walking around barefoot, you check those feet to make sure there's not an ulcer. If there's glass, don't walk over it. If you have shoes that are worn out and rubbing you bad, you've got to take, even though it may cost an arm and a leg, you need to get new shoes or find some ways to borrow someone's shoe, because we don't want things that are preventable to cause something that can be catastrophic. And I know Dr. Toby had asked me to some of the 5-year survivorships after a foot amputation in the diabetic population. Well, they had a recent study looking at the veterans of the VA, and they have tons of veterans with diabetes they can follow these on, and it was shocking. So the 5-year survivorship after a foot amputation in a diabetic veteran was less than 30%. That's worse than heart disease, worse than kidney disease, worse than most cancers. So it is a big deal, because it's not that the foot amputation is what leads to death. It is a manifestation of the change in lifestyle, the change in mobility, the worsening of other medical conditions that all are heralded by the foot infection and the amputation.
I don't know if you do a lot of prosthesis, but I see a lot of the modern prosthetics, like athletes, they have this prosthetic leg they can actually run on. What's your criteria for who gets a prosthetic leg? Is it if he's young and wants to run, or who gets a prosthetic? For example, you do a below the knee amputation. Does everybody get a prosthetic, or is it just based on insurance, or is it based on mobility status? What are your...
Well, I wish insurance didn't have anything to do with it, but the reality is those things have a cost, and if there's no payer to pay the expense, then you really can't get the prosthesis unless you find someone to donate it. But it's not just the actual device itself, it's the fitting, it's the therapy, it's the training, it's all the stuff, the accommodations at home that go with it that make it difficult. They've done studies looking at how well people can ambulate and how much energy it takes to ambulate with different prostheses. And if you're a child who had, say, a lawnmower injury to his foot and gets a prosthesis placed when he's 3, his ability to work with the prosthesis is like, I think Dr. Toby's referring to the Blade Runner from South Africa, who was running times that were almost competitive with the Olympians in the who don't have leg issues. That it's an issue of how much can the rest of the body accommodate you in order to be able to use the prosthesis. Because unfortunately there are issues with prosthetic wear, with stumps and getting ulcers, and just how much energy it takes the rest of the body. And so if you haven't moved much in 6 months and you got an ulcer on your foot, if you do, and you have, and unfortunately end up having an amputation, the ability for you to get up easily like nothing's going on with the prosthetic limb is not necessarily realistic because you weren't able to do that when you had your good foot before. And so that there are constraints to being able to do it. But if I have a patient who's willing and was willing to try and has the wherewithal to get his body conditioned and to be able to utilize it, I'm more than happy to try prosthesis.
Well, let me just reiterate what Dr. Spire said here, because he's saying that in the study the VA did, 70% is what you're saying is that 70% did not survive in 5 years after they had an amputation. Just to show you that the amputation is basically, and that's what I'm saying about collaboration between orthopedic surgeons and primary care and dietitians and physical therapy. No man is an island. Dr. Spires can amputate the leg, God forbid if he needs to, but you still need to see me to keep your sugar under control. You still need to see me to make sure we're on top of your blood pressure, because if all that is not on together, if the ducks are not in a row, a surgery, am I correct, is not just a silver bullet. It's not going to take away the problem. You got to get to the root of the problem, right? So I just want to make sure people understand that, because I have so many patients who think, oh, surgery just gets everything out of the, I'm fine after surgery. And it's not true, you know.
Well, I think everyone sees the people who have had surgery and are doing fantastic. And that's what our goal always is. But to get to that place, you have to get to that place. It doesn't come to you. You have to walk the path. And so I think, as Dr. Tobey's making a good point, is that once you've had the surgery is designed to affect a very small thing, and that everything else around that thing now should be able to work properly, or as good as properly as we can get it. So the onus goes to the patient to start using them to take the benefit of that thing. And if someone has a total knee and it's still sore and it's painful and is just frustrated that they're not getting better, well, part of that is probably a lot it's on the physician for not laying realistic expectations of what you should be doing when, how you should feel at this point. And then also knowing that everyone's different. Everyone sees the 95-year-old lady who's had a hip surgery who's walking the next day like nobody's business, and everyone's like, oh my goodness, what's going on here? And then you have the 65-year-old who can't get out of bed for 3 weeks, you know, and so should be healthy. And so everyone's different. Pain affects them differently. But I think it's critical to know that surgery is designed to address an issue, to correct something, to get something out that shouldn't be there. But it's the human body. It's what it's God's creation is truly what heals the body. You know, I can put a bone back together, but I can't make it heal. You know, only the body can heal itself, and that's a gift God has given us. But it's a gift that if we're not good caretakers, we can have big time issues. And you know, we're blessed by being diligent. You know, and stuff I don't know if we'll get to today, but it's just being active. You know, it's finding in exercise, and I want everyone to know, because everyone assumes this. How many people have come to me to get a total knee done because if they could just get the knee done, they could exercise and lose weight. A lot of the new data coming out about weight loss is that 100% of long-term weight loss, say you're going to lose 30, 40, 50, 100 pounds, has nothing to do with exercise. It's not because you exercised it off. It's because you change what you're eating, how you're eating, your thoughts on eating, your food. And what exercise does in that situation, it accelerates how fast you lose the weight. And what the benefit of exercise is it makes the body healthy. When you exercise, your mind works better. Your body works better. You feel better. You can move better. All those things go hand in hand. With exercise is technically the best medicine because it makes the body work like it's supposed to. When it comes to losing weight, you have to really change a whole bunch about what you do because your normal stuff got you in that situation. And so to lose weight and to keep weight off, you have to make changes to how you eat, what you eat. You know, you can do checks and balances of how many calories you burn versus how many calories you eat. You know, but the reality is that that's a whole different thing than my knee hurts so bad I can't exercise, thus I can't lose weight. Is that can really trip people up. And it's not that it creates an excuse, but it makes it harder to get motivated to do something big.
Right. That's spot. I'm talking about to some patients of mine. They show me their hands, and they see that their fingers are swollen in the joint spaces. I just want you to describe what that is, and what do you do in, I know you're not a hand surgeon in general, but you see a few patients. What do you do for diagnosis of the swelling in the joints, number one? And then if somebody has severe pain in this little hole here that they said, it hurts really deep in there, what do you do in that kind of situation? I think medically some people call this the anatomical snuff box, just because I know patients who may come in with those complaints. What are your recommendations in those classes of people?
So when someone has, looking at their hand, and you have little swollen knuckles, especially the middle knuckle or the one right out at the end, that's typically consistent with arthritis, the wear and tear, the osteoarthritis of the finger. Now, it's a very different thing if the swelling is the knuckles at the base of the fingers, and you see your fingers start twisting, where they're kind of leaning out to the side a little bit. I guess I should do it like this. That part, these are called the metacarpophalangeal joints, or MCP joints. These joints are worrisome for an inflammatory arthritis like rheumatoid arthritis, gouty arthritis, psoriatic arthritis. It's kind of scary sounding names. And that's something that needs to be addressed medically. When I see patients with arthritis of the fingertips, or the joints there, is that while cosmetically the way it looks may be bothersome and don't like the way it looks, that it's like all other arthritis. If you quit using it, you lose a lot of function there. So with those, I really want people to work on maintaining their motion, loosening up, keeping it loose. Some of my colleagues recommend doing little soaks in part vinegar water in the mornings, and that helps loosen everything up, and that's not taking any scary medicine. Arthritis medicine can help with that. Some of those salves, like two angry goats, or blue emu, or Australian dream, like those things can help loosen up those lineaments and those kind of things. When we start talking about the base of the thumb, that one thing is Dr. Tobey talked about the anatomic snuff box. I kind of think trauma first, is that's the classic place to hurt if you break a little bone in the wrist called the scaphoid. Now, that typically is something that because it's critical to normal wrist function, that's something that may end up being casted for 12 weeks or have surgery on, those kind of things. So if someone falls and the wrist looks okay, maybe a little full, but it terribly hurts to push in that little snuff box you get in the side of the hand there, that's something that you need to let your doctor know about. Now, a lot of people will get arthritis. It's a common arthritis called basal thumb arthritis at the base of the thumb, not at the joint here, but as we get, look here, right down here, or this part of the joint there. And what happens with arthritis, it tends to change the way it looks.
Right.
Sorry about that. And that what we can do with that is that there's a whole spectrum of things, from just keeping it loose, moving it. There's little braces you can buy at the store to give it some relief. We can even do injections in there. And then ultimately you can even get to the point where you do a surgery to address the arthritis. And most of the time it's instead of putting in a new joint, we actually take out the joint, and that really gets rid of the pain. It doesn't necessarily increase your function in the wrist, in the hand, but it's one of those surgeries for pain itself.
Okay. Now, let's talk about the shoulders. Now, if somebody is unable to lift their shoulders above their head, what are we thinking of? I mean, they just can't lift it, they can't go above their head. Is there any pathology or medical condition we're worried about?
Well, so when it comes to the shoulder, there's a couple things we worry about in the shoulder, especially when we lose motion or it's very painful with certain motions. A common one that I see a lot that's really scary because it seems to hurt so bad, can't sleep at night, is a condition we call frozen shoulder. What frozen shoulder is, it's still kind of a mystery to us doctors because we don't know exactly what causes it. We do know it's associated with diabetes, and sometimes we'll even find someone who's got frozen shoulder and we'll say, "Are you diabetic?" And they're like, "I don't think so." And they get checked out and they are. That happens a couple times a year probably. What frozen shoulder is, it's the joint capsule around the shoulder gets thickened and inflamed. We call it, the technical term is adhesive capsulitis. And we know it because it's loss of your ability to move your arm. So you're like, trying to lift it up, it just won't go. And then when I do it, which means passive motion, because I'm moving the arm, it won't go either. So that's the technical definition of frozen shoulders. You can't move it, and I can't move it. Well, how do you treat that? Well, a lot of times with frozen shoulder, if you push through some of the pain and work on stretching out and loosening it up, it'll start to loosen it up, and as it loosens up, the pain gets better and better. And there's lots of ways to do that, you know, but to get to the actual proper stretches to do, you know, I hate to tell people to get online, but you can get on YouTube and they'll show you stretches. You can come to the office. A lot of times, if I see someone hurting bad enough to actually come see me, is that we get them in physical therapy, and the therapist stretches them out and shows them how to do it at home. And we have little booklets. We can also do an injection inside the joint itself to calm it down.
Okay.
Another thing that we see that's very common in the shoulder is a condition we call impingement syndrome. And what impingement syndrome is, it's kind of the downstream effect of usually something causing some irritation above the rotator cuff in the shoulder. And to say one day you're dusting the ceilings and doing a lot of overhead work, or you know, and the next morning you try to lift that arm up, you're like, woo, something's going on in that shoulder. Well, usually it kind of starts out as a bursitis. But what happens is most people are tough enough, they say it'll get better, just give it some time, and they'll let it rest and relax. And then over time they notice, while it may not hurt as sharply as it did at first, every time they try to lift the arm up, it's still painful. So they wait longer and longer. And what happens is you've kind of accommodated or just changed the way you do things so you don't hurt that shoulder so much. And by the time you make it in to see the orthopedic surgeon, we do these little maneuvers, you know, down like this, we test strength, all those kind of things, and those are provocative tests because it hurts so bad when you do it. Well, what does that mean? Well, it means you've lost some of the tension in the muscles holding the shoulder blade down, and so the shoulder blade's kicking up, what we call winging. It's pinching on top of the shoulder. The more you rest it, the worse it gets. So it's one of those things about balancing. After surgery, doing therapy, well, without doing surgery, you need to do therapy to get the muscles balanced. The muscles in the back pulling as much as the muscle in the front, because the shoulder joint's a ball and socket joint. But in reality, it's a dinner plate with a ball on it. There's it's not a socket like the hip is. Okay. And so what keeps it suspended in the right place and moving like it should is the muscular balance around the shoulder. And when you get issues lifting it up, moving it, you overuse some things because you're still doing all this stuff down here. You're just not doing anything up top, and you start to get imbalance in the muscles. The other thing we worry about is what called, you may have heard of rotator cuff, is a rotator cuff tear. The rotator cuff, say this is the ball and this is my arm bone or the humerus. The cuff is a set of muscles that attach to that, and they would actually move the shoulder for all fine motions, whether twisting, turning, going up, going down. And if you tear off that cuff, the shoulder muscle most people think of is called the deltoid, does not have the mechanical position to initiate motion. So if you've got a rotator cuff tear, you can't lift the arm up. You're just like, hey, what's going on? You know, if someone's going to high five you, you'd be like, you know. And with the rotator cuff tears, depending on how soon. Now, especially it seems like some of the more mature ladies have just amazing pain tolerance, and they'll show up and their shoulder has terrible arthritis in it because you just on x-ray, they may not hurt so bad because they've just learned to adapt, not having the rotator cuff. But people who have a sudden tear of it can have significant debility, difficulty moving the arm, can't lift up like this, all those things. And when that happens, we do have good options to fix them if we catch it early enough. You know, usually within 3 months is that golden window to fix rotator cuff tear. So we don't want, you know, if it's going on and it's been 3 years, it's a little different situation than if it just happened, 3 weeks ago.
Last but not the least, before we go today, I need to talk about hips. It's probably one of the most common fractures in elderly people. What would you see if a patient comes with a hip fracture? What position, what would the hip look like? What would the knee look like from your experience?
If you're talking about how they present to the ER, if say your grandma fell down, what's
classic
going on?
presentation, right.
A lot of times it's more in the sense of what they can't do. And so they're laying down on the ground and you say, hey, granddad, let me get you up. And he's like, okay, son. And you try to pick him up and he gets up and he tries to put weight on it and he just goes back down again because that initial terrible pain. And it presents as typically pain in the groin. So groin pain, not pain in the buttock, in the back, or on the side of the hip. It's groin discomfort. And then also, in some people, it hurts all the way down to the knee. And I've had quite a few patients over the years who come in and say, my knee is killing me after I fell. You get x-ray of the knee, they're like totally normal. You get x-ray of the hip, and they have a hip fracture.
Yeah, the hip fracture.
Now, depending on how you break the hip, be something I know in the medical field it's always interesting to know is that what do we do and why do we do what we do? Is that if you break just the ball off, you know, if you just crumble it a little bit, we call that that's an impacted fracture or break of the hip. We can usually just put some screws across it to hold it in place. If you break the ball all the way off where it's completely free, that's where the positions are, the hips flexed and internally rotated, all that kind of stuff. And those we replace those with an artificial ball and a stem that actually goes inside the thigh bone. And a lot of times we'll hold it in place with, either, if the bone quality is pretty good, we can just put press fit where the metal has kind of porous material that the bone grows into to hold it there. Or if the bone's a little weaker than that, we can cement it in place. And on those, actually, we can get you up walking the same day or the next day. If you break it, not at the ball, but where it makes a bend going down towards the knee, these little bumps, I don't have a model to show you, we call them the trochanteric region. If you break there, those are ones we can fix. And that's where we use used to be they use plates and screws, but now we use a big rod that goes from the hip down towards the knee, and then we have a screw that actually goes into the rod itself, and they all lock as a construct, and that's actually strong enough the majority of the time that we can let you put your weight on it as you're comfortable right after surgery. You know, the goal with hip fractures is to keep you from laying in bed too long and getting out of shape.
So there's a move away from staying on the couch after surgery.
Oh, yeah.
Why is that?
You know, when they used to treat these, it was pretty much laying in bed for 6 weeks, and in the elderly population with those fractures, there was a 90% mortality rate. It was mind-blowing. I mean, that really drove orthopedic surgeons to find a better way to do it than to have all your 9 out of 10 of your patients pass away is not good. But even then, and the scary statistics coming out with hip fractures is that most people now, we used to think that 40%, but now it's somewhere around 60%, don't quite get back to the level they were at before they broke their hip. That's scary. And then all comers, whether you're healthy or bad, not healthy, whether you have dementia, all comers, the mortality rate right now is somewhere around 20 to 25% a year
after
a hip fracture. If you break both your hips in 1 year, your 1 year mortality after the second hip fracture is 90%.
Oh, wow.
So when you look at cost, hip fractures cost us way more than breast cancer, way more than anything else, essentially than heart disease, in terms of how much care is required, loss of time, and the risk of mortality afterwards. It's really a big deal to break your hip. And as Dr. Tobey was saying, is that the key is staying active. The key is to go dance. The key is to do Tai Chi. The key is to keep your body in shape so you don't fall. All right?
Thank you so much for staying with us. This has been an excellent topic. We've talked with Dr. Spires about joints, about how to stay healthy in the midst of arthritis, what orthopedic surgeons will do for you. Look him up at Northeast Orthopedic. Join us same time next week. We'll have another awesome time talking about a topical medical thing that you might want to know a little bit about. It's been a pleasure being with you. Don't forget, Jesus is Lord. God bless you. Bye.